Hello, my name is Marques Borrello, and I would like to welcome you to the Myeloma 2017 meeting that is currently being held in Edinburgh. I have the pleasure of being here with my colleagues, Dr. Cho and Dr. Mutis, and we would like to talk about some of the highlights from the immunotherapy session. Specifically, to get started, why don't, Dr. Cho, you mention the story of where is the role of immunotherapy right now in myeloma, with the exception of CAR T cells?
I think there's a lot of interest in different areas of immunotherapy for myeloma, but there are definitely challenges that have presented themselves. Although CAR T cells are getting a lot of press now, and they're an important topic for investigation, but it's just one part of the so-called cancer immunity cycle. How the immune system recognizes cancer cells, kills them, and is able to propagate that immune response. So it's important that we continue investigation into other areas that affect other parts of that cancer immunity cycle, because ultimately we're going to need to put together different types of immune therapies that affect different parts of the cycle in order to create broadly applicable, effective therapies.
Right. I mean, I think one of the things that may be difficult for a lot of people now with the plethora of therapies available is that obviously it's not a one-size-fits-all. I mean, there may be certain subsets of patients or of disease settings in which immunotherapy may work, and certain modalities in which immunotherapy may work. And I think in terms of the CD38, initially, while targeting specifically a molecule on the myeloma cell itself, you presented data about its effect actually on the immune system and generating sort of a vaccine type of response. So if you would like to mention that a little bit.
Yes, that's definitely very interesting, because actually we started the CD38 targeting as a targeting molecule on the myeloma cells, and you see that nice responses are happening, but we discovered all of a sudden that actually daratumumab, which is targeting CD38, is doing something else. It is actually activating the immune system by depleting the regulatory cells of the immune system. So that's actually a game changer in our thinking now. So actually, are we always targeting by using these kind of chemotherapies or other type of therapies, are we always modulating immune system, yes or no? So actually that's an interesting question from my point of view, especially from daratumumab. So if we target the immune system in such a way, could we, for example, prevent or circumvent the what we call now the individualized therapy of the patient? So can we generate some therapies which are possibly applicable for many patients? So that's another interesting question, which brings us to actually the combination of immune therapies with genetics of myeloma. So actually some patients maybe are responding, some genetically identified patients may be responding to immunotherapies better than the other patients.
Yeah, I mean, I think you bring up a good point. There's clearly evidence with a lot of solid tumors that hypersomatic mutations have been associated with improved responses. I think there is some talk within the myeloma community that certain translocations, such as a 414, may be associated with a higher response. There was some mention about the somatic mutations that, while relatively lower in myeloma compared to a lot of the other diseases such as non-small cell lung cancer, in which checkpoint inhibition has worked very well. Nevertheless, hypersomatic mutations are present. I think, how this is going to play a role is questionable. There was data presented by the COMPASS study that, in fact, the higher hypersomatic mutation was associated with a worse outcome. But to be fair, that was in a setting of chemotherapy. I think when you integrate that with immunotherapy may be a different story, and the obvious question then becomes with checkpoint inhibitors, where I think a lot of the data in solid tumors has come out. And recently with myeloma, as we all know, the FDA has put a hold on all checkpoint inhibitor trials, at least with PD-1 blockade and an IMiD. But do either one of you think there's a role of PD-1 blockade in myeloma in the current setting in which we're living now, with the FDA currently being on hold?
Well, my hope is that the hold is eventually lifted once we identify mechanisms to safely conduct such trials. Because the fact of the matter is there's very good evidence that checkpoint inhibition does work in myeloma. So the question is, how can we apply it safely? I think you brought up an important point that somatic hypermutation and DNA damage repair signatures are important biomarkers in solid tumors that predict response to checkpoint inhibition. We don't know if that's true in multiple myeloma yet.
With regard to immunotherapy.
Absolutely,
Yeah.
and we need to know those kinds. We need to understand that aspect of the biology. What are the tumor intrinsic factors that influence the interactions with the immune environment? And Dr. Mutis' point is very important too. We're targeting molecules in myeloma cells. Myeloma is a disease of the immune system, okay? And if we're targeting molecules, receptors, markers that are present in myeloma cells that may also be present in normal plasma cells and other cells of the immune system, they're going to influence the immune system. It may be positive, as is the case with daratumumab. It may be negative. We have to see through clinical trials and correlative studies.
Right. The other things that were brought up, not by the two of you, but I think for purposes of this discussion are worth mentioning, were bispecific antibodies and oncolytic viruses. I think each one of them represent unique aspects. I mean, in a way, I view bispecific antibodies as a CAR T-cell light therapy. It's still a targeted therapy. It somehow engages the immune response, although whether it actually generates memory or just activates the T-cell, I think remains still to be determined from the data that is being generated. But I thought it was interesting that there are a variety of different approaches, from BiTEs that lack an FC fragment to novel therapies that are targeting now multiple epitopes and now have an FC, so they can be given over a less frequent timing. Is there anything else the two of you think is worth mentioning with regard to these bispecific antibody approaches?
Well, one thing has been addressed very, very well in the discussion of the session, that is bispecific antibodies, are they really working without any co-stimulation, first of all? And the second is really, is there a difference between CAR T versus bispecific in the generation of memory? So actually we think that bispecific antibodies or BiTEs will never generate immune memory. But is it really true? We don't know, because is there an epitope spreading happening there?
Right.
We don't know that yet. Also not in the CAR T-cell therapies, because actually many, Dr. Evigan just very nicely showed the dendritic cell therapies work very well. So actually they could induce T-cell responses against myeloma. And he is even thinking to combine these therapies with CAR T-cell therapies because of the probable epitope spreading effects of the CAR T-cells or bispecific. It's in a whole area of more thinking about immunotherapy. Actually, we have to think a little further than doing targeting at myeloma with one single agent. And actually, I think that in the future, at least in the near future, we are going to learn a lot about how we can effectively target myeloma by immune system.
Yeah, and I think on that point, the one thing that I've always been amazed is the clinical response that a single antigen with regard to CAR T cells can actually achieve. Although interestingly in ALL and in diffuse large cell lymphoma, we're seeing what I think was expected, which is the development of relapses with antigen escape variants, that they're negative to the original target. And so from that approach, a more global approach, such as an oncolytic virus or a vaccine or polyclonally activated T cells, I think have significant benefits with or without checkpoint inhibition or a variety of other things. But I think, nevertheless, what I take away from what's really been happening over the last several years is that immunotherapy, I think, is here to stay in multiple myeloma. I think we have gone from a period in which it was sort of phenomenology to really dealing with defined clinical benefits. I think the next 5 to 10 years are going to be focused on understanding who is more likely to respond, such as the case, for example, with the checkpoint inhibitors that you brought up. And to minimize toxicities, as will need to be the case with a lot of CAR T-cell therapy.
I think where to use it is also going to be important. It's not going to be a one-size-fits-all approach. If you want to have long-term remissions, disease-free survival, you do presumably need memory. But if you need to gain control of aggressive disease in a short period of time, you need high levels of efficacy. And that's not mutually exclusive goals. So it may not necessarily matter if a BiTE or a CAR T doesn't induce memory. If you need to have a non-chemotherapy, non-cytotoxic chemotherapy alternative for patients who have aggressive or progressive disease, versus if you want to go for cure in a patient who is suitable for a combination immunotherapy regimen.
Yes, for definitely, actually all these new immunotherapeutic approaches are making the tumor load lower. So actually they all destruct the tumor, and then it could lead to a normal T cell response, which we actually don't know yet. So and that might be. You could also see the CAR T cell therapies or bispecific therapies as a kind of conditioning or consolidation of the patients. And then the normal immune system, if it is working good enough, can take over.
Right.
It could be possible.
But I think, I'm not sure if we'll ultimately end up curing myeloma, but I certainly think that with these approaches we're going to see longer term remissions.